Today, we are looking at one of the largest federal rural health investments in recent memory, the CMS Rural Health Transformation Program. $50 billion over 5 years, approved for all 50 states on December 29th, 2025. And the headline number, while real, is hiding the actual story. Here are the three things we want to cover today. First, how the money is actually divided. Half of every state's allocation is split equally. That works out to roughly $100 million per state per year, regardless of how many rural residents live there. The other half is merit-based, scored against state plans. The result is a range from New Jersey at $147 million total to Texas at $281 million. Alaska works out to about $990 per rural resident. Rhode Island comes in at over $6,000 per rural resident, which sounds remarkable until you realize their rural population is so small, the per capita math is almost meaningless as a policy signal. Second, what the money can and cannot do. The law authorizes 6 categories: prevention and chronic disease management, provider payments, consumer-facing technology like apps and patient portals, training and technical assistance for remote monitoring and AI and robotics adoption, workforce with 5-year service commitments, and IT for cybersecurity and operational efficiency. What is not allowed: construction, cosmetic upgrades, independent research, restricted telecom equipment, and here is the one that matters most. There is a 5% cap on electronic health record replacement spending per state. Texas has $281 million. 5% of that is roughly $14 million. That is not enough to migrate a statewide rural hospital network to a new EHR, which means anything built for this program has to work with the systems that are already there. Third, the broader capital stack. The RHTP does not exist in isolation. HRSA's Federal Office of Rural Health Policy distributes more than $400 million per year across rural grant programs. The FCC Rural Health Care Program is capped at $744 million for fiscal year 2026. USDA deployed nearly $500 million to rural healthcare in fiscal years 2022 and 2023, combined through a program most healthcare observers have never heard of. There is a brand new HRSA Rural Hospital Provider Assistance Program, with applications due July 1st, 2026. Stack all of that together, and the Federal Rural Health Capital Surface in fiscal year 2026 is north of $11 billion. None of those programs share infrastructure. None have unified applications or reporting. The fragmentation across all of that spending is the real story underneath the $50 billion headline. The backdrop for all of this is a rural hospital system under serious stress. 152 rural hospitals have closed since 2010. 432 are flagged as financially vulnerable right now. In Texas alone, 67% of rural hospitals are running negative operating margins. The reimbursement structure for rural facilities has been broken for years: small volumes, heavy Medicare and Medicaid mix, zero commercial leverage, fixed costs that do not scale down with patient counts. RHTP is partly a policy response to that crisis, and partly an offset to the Medicaid cuts in the One Big Beautiful Bill Act, which KFF estimated at $911 billion over 10 years nationally, with $137 billion of that hitting rural Medicaid specifically. That is part one of the full analysis. The article goes much deeper on what the procurement structure in each state means for vendors, why the EHR cap forces a specific product strategy, and what the operating layer that actually connects this capital stack to rural providers looks like when you try to build it. Subscribe to On Healthcare for Part 2 and the full analysis. Link is below.